balance, and it's a very common topic at work, even in our day-to-day lives. Most of the time, women are constantly handling many activities from their professional life. They have to discuss what they're going to maybe wear tomorrow. They have to take care of the family. They have to take care of what lies ahead of them at work. And also, they're the same people who also frequent religious centers, so they also have to take care of their spiritual life. You realize most of the women are the ones who pray for the homes. So because of all that, they really have to multitask. And for a fact, maybe I think I can say today that most women or ladies were able, differently able to do many things at the same time. And now I beg to ask this question. For us women, we need to first learn what works best for us. But yet again, we need to first learn who you are, what you possess, because everything is already within us, and it's simply a matter of uncovering what you have in there. So sometimes we take a long route trying to describe who you are not, trying to live in a profile of what people are profile, living in someone else's lens, yet you're not able to say who you are really. So I think it's time for us women to come, or even okay, men and women, sorry, because it's a gender docket, you have to say we have to talk about both gender. We have to find out who is in your circle, and if that circle has the right people, and if they're helping you move towards the right direction, because you can be in the best circle, but they're pulling you towards different centers. So, and then also again, as women in the forums that I attend most of the time, you find that you can go for a gathering, maybe a women economic empowerment program, but then they have many other issues that have not been addressed. You find that maybe the panel that's on board is only focusing on what has brought them there, maybe teaching women in the entrepreneurship skills. They forget that these women left their homes, and where they're coming from, maybe they had other medical issues that were not addressed. So in this department, I've tried to integrate. You realize that whenever I have a sporting event, because I also I'm in charge of the sports department, we use that opportunity to discuss all the cross-cutting issues that could be coming from the community, the various homes that they come from. I've used sports as a tool of a denominator, like to bring people together. And you realize at the time I do the mental checks, that's the time I do the medical examination. For example, the last time we had the World Day of the Elderly on the 3rd of December, on 1st of December, sorry, we were able to bring women, or I mean the elderly community, the women who had, we brought a partner that was doing a blood pressure monitoring. And in that same gathering, we were able to see the prevalence of how many people do not have NHIF baby, how many women and men had not gone for their last checkup, how many had not complied to their treatment. Those were given maybe a review after 2 weeks, but then you ask them, "Bona ujaenda?" They're like, "No, you see, I already got this medicine and I'm feeling better." So I feel like in these forums that we go for, maybe as you go, just try and see what else can you teach these women down there, so that you just don't focus on one thing. Can we be at least holistically? Can we handle these women, or can we empower them holistically? As we're teaching them the tech piece, as we're teaching them the sporting activity, or as you're handling this particular special population. For instance, the other day we were having the Widows Day on 25th of June, on 27th of June, sorry, in Mariakani. We were able to find out that women there who have maybe the young widows, they did not know what next. They're like, oh, now mzee ameenda, mimi ni mdogo nataka kuolewa. So we try to pair them with the older widows who have been there before to at least give them some psychosocial support. So it is through this many engagement that you're able to treat women holistically, and that is how you're going to make them have the work-life balance and feel appreciated. And again, as an individual, you should always pat yourself in the back. You should always ask yourself, as I go to bed today, am I happy with what I've done? Have I ticked all my boxes? So it's good to appreciate yourself first, and also put your circle together and maybe empower them differently. And also it's also good to find out whether the person who put you in that circle is also doing it, because sometimes as a leader, no, that is the governance and women, you find that you do not have the best circle, you're alone, you want to move forward, but people are really holding you back. So it's always good to strategize as leaders, women leaders, to find different circles that will help you function well, and that will help you empower other women. Because as a leader, again, you're not there to serve a particular group. You're a leader and you're supposed to lead in the house and also lead in the office. Next slide, please. So the county government of Kilifi has been in the past hitting the eyes for different stories. Some of them are horrific. We have many cases of defilement, incest, teenage pregnancies, naming of the elderly, and also the recent one was the Shakahola incident. And if you look at all these incidents, they're all cross-cutting issues and all piling up under retrogressive cultural practices or social cultural norms, as I had my colleague, Dr. Pacifica, discussing in the morning, whereby only she was discussing about where only men can only land on land, which is not true. In our community, we have the same problem, yes, but again, Kilifi counties are mostly a patriarchal society where men are the decision makers, and we women struggle really to fit in. So it is our duty now as leaders or as women empower, I mean, the circle through these partnerships to go and look for these people who've gone through these horrific stories to bring them back. So through the Department of Gender, I was able to look for partners who focus only on psychosocial support. I only picked that aspect in my department because I'm a trained psychiatrist and I wanted to see how else can we empower women in as much as we're training them to build themselves and giving them financial freedom. How else can we change their mindset? How else can we learn the people, the kind of personality they have, and I was able to look and identify it at the grassroots level. And that has also somehow helped us reduce the number of teenage pregnancies, the number of maiming of the elderly, because we had many, many programs. For instance, we had the UNICEF coming in with the positive parenting program, whereby we were able to have intergenerational gaps. We were able to pair the youth and the woman who is in the village to see why is it that we're not gelling in together. Yet this lady here, the elderly now, is the one who was the custodian of this intangible heritage. These are the people who are going to teach us about the culture that was there before. Yet this other young man here feels like this old man is busy trying to take my land or my wealth. So let me just kill him so that, or kill her, and so that I'm able to get my wealth. And also, because we see again, there's also the literacy level, low literacy levels. This elderly does not know how to read, does not know how to sign. So this young man here will like, Baba, just sign here so that I check this. And then if you find that you're really, really adamant, they kill you. So like as at now, as at 2019, most of those who had white hair were maimed and they were killing all gender, the male and the, as long as you had white hair, you're told you're a witch, you're a wizard or a witch doctor, and now there was that conflict. But now through these programs from UNICEF and other partners, we've been able to change that, and also we've been able to come up with policies that also guard the people who have undergone gone through these processes. And in teenage pregnancies, also we're able to work with the Department of Health. We work very well with Kenya Red Cross. We have so many partners in Kilifi, and also we were able to come up with programs that we teach this young father, the Linda Dada. We told the young fathers, can you try and find out why we have so many teenage pregnancies? So with the help of having the med engagement, we've also been able to lower down to lessen the prevalence of teen pregnancy from 31% to 12.5%. And then again, we've also worked on policies, as I said, because we cannot achieve much without good policies. And late next month, we'll be having our first anti-GBV policy. And I take this time to invite you all. I will send you invites, and I hope I'll be seeing most of you. Through the leadership of His Excellency, the Governor of Kilifi County, Gideon Meta Mungaro, who is a very transformative leader, he's been able to empower women differently by making sure his cabinet is 50-50. We are a cabinet of 5 ladies taking care of different topics, and the other 5 belongs to the gentleman. This is also a way of enabling and empowering the leaders, because now they believe that okay, one day if I do this and this, if I'm able to go to school and achieve this, one day I'll be a waziri. So these are some of the things that have also helped us get to where we are. And also when he was watching this CDP on the 15th of June, he emphasized mostly on the fifth thematic area, which talked of the public-private partnership. This is a way of trying to bring all the partners on board. Instead of having different partners doing different things, His Excellency has asked us to bring all the partners, we map them out, and then we say, what is this partner doing in matters gender? What is this partner doing in matters sports? What is this partner doing in matters culture, heritage? And then he's also asked us to work with the national government so that we do not have repetitive programs. And that is how we've managed to empower the women, youth, and PWTs from Kilifi County through different capacity building programs. Next slide, please. And also the evolving mental health space requires a comprehensive, transformative, and collaborative approaches. We say comprehensive because we cannot work alone. as you know, like this political space sometimes can have very many um, linkages. Some of them can be, some of them might not be really working, but then through we've adopted the interdepartmental approach whereby if I have an activity, I inform my colleague, and then we see how we can cooperate. So that is the comprehensive bit. And then the transformative is whereby we engage now the national government to see. Then collaborative is when we look for these other partners like the non-state actors and the NGOs. So for instance, when we just joined office, the UN Women offered a 2-day training to all the CCMs, that's the county executive committee members. We wanted this all the other waziris to be able to understand what this department holds. So when it comes to the gender responsive budgeting, be able to allocate some funds that will be taking care of the various women groups and the youth groups and the PWDs. For instance, I'm able to work with the Department of Trade and tell them, since you have the Wezesha fund, which is our revolving fund to enable these three groups, the women, the youth, and the PWDs, try and find how many groups you'll have assisted in maybe the first quarter. So that's when your budget, and then also was able to talk to the CC lands was the region come to tell her, as you're busy constructing maybe new buildings, can you make sure you have a ramp so that we have the PWDs involved? And also, as we are busy talking about the land educated issues, can we have women champions that will be out there training women on how they can fight for their rights and also be owners of land? When I also talked to the Waziri Health, can we get champions that are going to talk about sexual reproductive health practices? So it is through this multi-departmental or interdepartmental approach, whereby that other departments, when I'm having an event in my department, they come in and hold my hand and say, okay, let us help you in this way. And that is how we are working together as a team. When it comes to the collaborative approaches, as I already said, we have different thematic groups in Kilifi County that whenever you call upon the and again, also we have the Cambridge, we have the research center, and through these many approaches, we've been able to build resilience to our women at the grassroots level, and then we also identify champions at the world level. For instance, I have champions who are taking care of now. Those are women champions, by the way, who are taking care of the county disaster management risk. Today they were having an activity, and today is the World Drowning Day, World Drowning Prevention Day. So the women are like, Waziri, let's do something tomorrow. Like, go for it. What do you plan? We want to have a drill whereby you're going to go and rescue women and rescue people who are going to be drowning, for instance. So for each director that I have a champion in gender at the world level. We have a champion in youth from the 35 wards. That is, so out of the 7 directors that I have 35 champions, and all of them, I integrate them and teach them the same things on matters mental health support. I take them for training at least after every 3 months. We tell them, and then we also have Kenya Finland bilateral group that came in and helped us with the psychosocial component in the department. So as you see, all these champions that I'm discussing here have a component of psychosocial support. They've all been trained on counseling, on mediation skills, and now they're able to cascade that information upwards because all of them are coming from the grassroots level at the ward level. Kilifi County has 7 sub-counties with 35 wards, and that is how we've been able to lessen the burden of mental health. And again, we have a partner that I'm seeing here. I'm so happy to see you, Dr. Samakobe, moving the goalpost. Through her partnership, through moving the goalpost, we'll be able to have women champions at the world level who go out and talk about sports, but not sports alone. They empower, they build resilience. So those are some of the things that we've done in Kilifi County to build resilience among our women. Because again, if you empower a woman, if you change her mindset, she'll be able to work everywhere. Because again, there's no health without mental health, and mental health is always wealth. Next slide, please. I think I already discussed about that. And then now the second line, we took the Identified Champions through a 6-week course on psychosocial support classes. We normally have classes twice a week, the Kenya Finland government and the Kenya Circle. So we don't normally come and train. So this, the second line, this is the departmental thing, whereby everyone in my office is able to, whenever they receive a call, maybe someone is in distress, they're able to listen to them and link them to the next link of care. So that I felt like when I joined the department, most of the staff did not know how to handle these GBV cases. We did a gender desk. We have a gender desk, and all the gender officers are trained. We also partnered with Kenya Red Cross and trained the the policemen or the gender officers and the police service that is in Kilifi. We've also trained the chiefs on gender so that as they go, as they talk about, as they listen to their issues, as sad as they may be, they're the same people to tell them, you know what, you've listened to you, but this is the best place for you to go so that you do not have these cases going on. And I'm happy to say that nowadays our women are empowered. They can speak up, they can say, no, this is not right, I will not. So I feel like they are being empowered, and through them raising their voices, they're able to not go and look for other forms of economic empowerment. So for me, I just emphasized on mental health resilience through the various directors that I had. Next slide, please. We have so far trained a total of 195 counselors on life skills and 78 mediators. This is now at the departmental level. And this is not the only initiative. We have done the elderly, maybe I talked about the elderly, I've talked about the teen pregnancies, about the substance use. We have our Kilifi youth policy that is in the pipeline, and I'm sure KU Rehab is going to assist me on this. We have tried to map out in the different sub-counties where we have high incidence of substance abuse. For instance, we have realized that Watamu and Malindi have the highest cases compared to Mtwapa. Mtwapa being border, it's a border sub-county because it's a link between Mombasa and Kilifi County. So we normally have issues. We find that most of the users are from Kilifi or working in Mombasa. So we have also partnered with Mombasa County to see how best we can work together so that whenever we need to do some program to just have a one, we have the JKP model, the Junior Counties of Pwani, because these are counties that are having similar issues, similar challenges. You find that there's a lot of radicalization in Mtwapa, but there's more substance in Watamu. There's a lot of maybe sex workers in Mombasa, and then we have elderly, the building of the elderly in Ganja Devas. So we discussed as a team, and I was happy that when we met last time on 4th of July, KU Rehab was able to identify which county has what, and because we were given a chance to describe. I like the way Taita Taveta was able to come with they have partnered with Blue Cross to see how they can map out where they have the highest risk of GBV. And that was a learning tool for us. On our end, from our end now, Kilifi County, we mapped out which cases, which wards have the highest incidences of teenage pregnancy, so that we send in more support there. We send in more psychological, teams. We send in more sexual reproductive youth. We send more youth-friendly spaces. We send more of the ICT experts. So these are some of the things that we've worked in Kilifi County to reduce the burden of mental health and also to empower women. We've also had the Linda Dada Initiative. Linda Dada Initiative is whereby we map all the border, we put them in a circle. We don't charge them, we do not give them, they don't pay the 300 shillings parking fee. His Excellency the Governor waived that so that we use the same border riders to become our champions of GBV. They're the ones who tell us, oh, unajua waziri jana nimepeleka wasichana watano huku, inaonekana huku kuna a lot of GBV. So we send our teams there. So it's through this collaboration that we've been able to make this a success. I already talked about the intergenerational dialogues where we bring we bring the interfaith councils, we bring the spiritual leaders to talk to this youth. We bring the teachers. We normally use the interdepartmental approach. The county disaster management risk response is one that I was telling you about, where we've mapped out champions, women champions in all the wards. We're going to talk about a fire. They now know how to evacuate a fire, how to evacuate someone from a fire. They have taught people on soft skills, on coping skills. About the gender-based violence recovery center, that was about 1.5 to. Okay. And also we have okay. Is there a problem? I'm almost winding up. We have constructed a rescue center. The county government is soon going to have one, and this will also have the psychosocial component, and also have the empowerment place where women can be coming to do their cottage industries and other forms of empowering them financially. And we've also partnered with Action Aid to put up a rescue and empowerment center in Garashi later this year. Next slide, please. county continues to partner with various stakeholders to help women empowerment programs, and we shall soon be signing an MOU. This tripartite MOU between Kenyatta University, Innovations for Poverty Action, which is a non-profit corporation, and the county government of Kilifi will focus on and collaborate in 4 key areas. That's capacity building and training partnerships, research innovation partnerships, community outreach partnerships, and policy formation for various policies. As I asked them, we also want them to help us with the Kilifi policy and the child protection policy and the social protection policy. And this will be through evidence-informed policy processes, needs assessment, and the implementation frameworks. Next slide, please.
Yes, Dr. Ruth, as you
so through the Department of
given
Gender,
you 20
we
minutes.
Collaborate with various departments at the county level and national level to ensure that no one is left behind in this tripartite project. Because once you build mental resilience in women, they'll be able to achieve more on their own.
It seems that there's someone who has logged in the meeting, and that's why you're getting the echo.
Sustainable developments to our community and institutions.
Anyone in the venue has logged in the meeting.
One another, hold each other's hands, pat each other on the back, blow one another, reassure one another with a smile, and also do the mindfulness, because it's the new big thing anyway. Mindfulness is whereby we maintain our moments by moments of our thoughts, feelings. It's like wanting to know you're present, you're using the gender lens. And the 3 qualities of mindfulness are intention, whereby you choose to cultivate your awareness, know your surroundings. Are you at the right space? The other quality is attention. You need to live in the present. Whatever happened last is already gone. Just focus and be attentive on your present situation or present life. Live in the present. The 3rd quality is having the right attitude. Being kind, being curious, and not being judgmental. Those are the 3 things that all women should have. If you practice mindfulness, your life will be okay, and you'll be able to achieve more, because right now we're living in a very profound time. And there's a lot of nature and culture conversations that are coming together, but we need to live in the present. And we need to be women who really keep on trying on even after failures. Just stand up and walk and look for the right circle. And we believe that each attempt can manifest and bring a better outcome. Next slide, please. I think that's my last.
Okay, Dr. Ruth Masha, because of time,
we're
going to ask you to summarize in just 2 minutes.
Self-care approach is where you put yourself first and find out what, because there's no you can give from an empty cup. You need to appreciate yourself, love yourself more, and you'll be able to give out more. And then you need to look for timely interventions. As at now, we have so many. Between September last year, we had like 4 cases of suicide, and those who died by suicide, 2 of them were men, the other 2 were ladies. When I went down to ask what was the problem, so this lady was busy writing notes, but no one took the bother to take her to the point of care. So it is always, if you feel like one of your colleagues is going through a phase, please ask for professional support. Timely intervention is the only way you're going to build each other as women, and also not forgetting to have to practice community kindness. Because again, you may be doing the right thing, but maybe the community is not there with you. So, but by you offering community kindness, they'll be able to see what seed you have in you, and they'll bring themselves closer to you, and then you'll be able to share what you have in you, and then you'll be able to grow another woman. In conclusion, I would like to urge each one of us to enhance their work-life balance, because you all have different needs. You cannot say, adopt mine. For me, I would want to go and dance after work, or I want to sit and read a book. If you want to go, just make sure you just live with the right space, the right people, and live in the present. And also to seek possible relationships that are healthy and that can promote our mental well-being. Asanteni sana, and God bless you all.
Let's applaud the presenter. Thank you very much, Dr. Masha, for the insights that you have shared. That's a power-packed presentation about the programs and the interventions that the county is taking. And we wish you will stick around for the next to wait for the next presenter to make a presentation, so that we can take a few questions from the audience. So our next presenter is Doris Botta, who is a senior advisor, as I had said, with the Save the Children US. And we have 10 minutes for this presentation. Then we're going to have a short session of questions from the audience. Thank you.
Good afternoon, everyone, and my apologies for the significant challenges today with the internet. And I was also running for another meeting at 3, but I'm happy that I've managed to join the call. And apart from that, I'm also happy to hear from the Kilifi team, because Kilifi is one of the counties that I have supported through the Management Sciences for Health organization. And more or less what I'll be speaking about today is something that Kilifi County has been able to implement. I hope you can all be able to see the slide, but I'm not able to move.
We can see now.
Please confirm that you can see the slide.
Have different presentation.
Yes, we can see it.
So I'll continue hoping that you can hear me. Okay, thank you.
Okay,
now,
go ahead.
Linking everything to health, I just wanted to start with what Dr. Gedenji Getahi, most of you must be familiar with him. He's the CEO of Health Africa. He said that health is not a sum of healthcare workers, health facilities, and technologies, but it's a sum of all human development investment. And this includes women investment as well. And today I'm going to touch more on water, sanitation, and hygiene in healthcare facility, which is a health investment. And if we do not really take care of water, sanitation, and hygiene, and infection prevention and control in healthcare facilities, then it becomes a cost that the country is not ready to incur. So what is this water, sanitation, and hygiene? Water, sanitation, and hygiene, basically it's the infrastructure, resources, services, and practices in a healthcare setting. And we are talking about the practices, we are talking about the infrastructure, we are talking about the operations, we are talking about capacity building, the healthcare workers, the patient, and the community, to ensure that we overall have a safety area to work on. Now, I'll be talking about the link between women and water, sanitation, and hygiene in a little bit. But before I get there, I just want to touch about the link between WASH in healthcare facilities and the Sustainable Development Goals. Now, WASH will capture under Goal 3, where we have the decrease in the number of deaths and illness attributed to unsafe WASH. We'll also touch about the global maternity mortality ratio, and we know that we have a lot of healthcare-associated infections that increase the mortality, especially in healthcare facilities that do not have good infection prevention and WASH programming. And then Goal 6 of SDG is also on water sanitation, specifically talking about sub-clause 6.1 and 6.2, where we advocate for achieving access to universal safe water, sanitation, and hygiene for all. Now, how did it start? It all started around 2018 when there was a call of action by the then United Nations Secretary General, and he mentioned that every member state needs to implement water, sanitation, and hygiene and infection prevention and control efforts. And this led to WHO and UNICEF are developing the global monitoring indicators to be able to track water, sanitation, and hygiene practices in healthcare facilities. Now, what are we looking at? We are looking at an angle where we have a target of ensuring that every healthcare facility has water that is improved in a location that can easily be accessible. We want to ensure that there's sanitation in every hospital, where improved sanitation means we have at least one dedicated toilet for staff, at least sex-separated toilet with menstrual hygiene facilities for women, and at least one toilet that is adapted for people with limited mobility. And when we talk about hand hygiene, we want to ensure that every facility, and especially the point of care, have adequate water and soap, or what we call the alcohol-based hand rub or sanitizers, and that every single toilet, 5 meters apart, there's a water facility. We also want to ensure there's proper healthcare waste management and environmental cleaning that have the relevant protocols and trainings in place. Now, what is our goal? We do not want to ensure that, water is contaminated. We do not want to come into contact with the excreta or the feces that emanate from our facilities. And so this is now a photo that shows improved water facilities versus an improved sanitation facilities as well. Now, WASH has become a little bit seriously taken in healthcare facilities because now we have the World Health Assembly Resolution 72.7 that says and urges government to be able to adhere to water sanitation and hygiene. So it's no longer business as usual. And our global target is to ensure that 50% of all healthcare facilities globally have at least water sanitation by 2022, which has now passed, but by 2025, at least 80% of healthcare facilities have also achieved this. But our ultimate goal is that by 2030, all the facilities, regardless of their geographical or religious background, have all these targets that we have spoken about. Now, what's our reality check? Where are we right now globally? Sitting at the global level, it's very unfortunate because only half of the healthcare facilities have basic water facilities. And in sub-Saharan Africa, only about 13% of healthcare facilities have basic sanitation services. And only about 39% of these facilities segregate waste according to the recommended standard. So you can see we are still way, way back, and it is even worse in low and medium income countries. And so what is the role of this WASH? Why are we talking about WASH and women? Because it helps slow the spread of antimicrobial resistance. It helps improve the quality of care. It helps prevent the spread of hospital infections. It also helps us curb diseases like the COVID-19 pandemic, cholera, among other pandemics. It also helps us to improve the safety of deliveries and reduce preventable maternal and newborn deaths. And ultimately, it helps us save money because it's our best buy-in where we are able to produce about 50% return on investments. And so connecting universal health coverage and quality of care is where we are talking about people-centered driven healthcare facilities. It's where we are talking about safety, effectiveness, and efficiency, where there's equitability. Every woman has access to some of the services and all the services that are required, and that the services come in a timely manner and that they are integrated with all the technology that is required. And for all of us to be able to achieve universal health coverage, we need to ensure that there's infection prevention and control. And infection prevention and control cannot happen without water, sanitation, and hygiene. So you can see the connection across all the things that we talk about: financing, economy, the population coverage. There's no economic outcomes without health. So what is our role as women in advancing WASH and the overall quality of care? It would be interesting to know that 75% of healthcare workers in healthcare facilities are women. I'm sure you might not be knowing this. And this equates to about 3/4 of the global workforce. So I'm going to pause there so that we can all internalize that 75% of healthcare workers in healthcare facilities are women. And further, about 17 million mothers annually give birth in a healthcare facility without water, without sanitation, without hand washing. And this predisposes them to healthcare-associated infections, leading to maternal and neonatal deaths. So these are the facilities that you and I are visiting. These are the facilities that our mothers are visiting. These are the facilities that our sisters and our grandmothers are visiting. So definitely, wash is also a determinant factor for nutrition outcomes because you need water to be able to cook. And investment in WASH contributes to reduction in sexual and gender-based violence. So women and girls often bear the responsibilities for WASH, including water collection, cleaning, cooking, and childcare. So how do we advocate for gender-responsive WASH? By involving women and girls in planning, decision-making, and governance of WASH services, by ensuring that women are part of the discussions in all emergency health activities, including WASH, and that they are informed on preparedness and response and funding initiatives that lead to sustainability. We also want to ensure that we explore all opportunities to support or create knowledge sharing opportunities among relevant WASH and other stakeholders. For example, the platform that we have today. And some of the key elements for gender-responsive WASH is strategic planning, where we have to ensure that we do analysis to be able to understand the current situation in healthcare facilities, what are some of the bottlenecks and what are the opportunities that exist, and more so talking about the gender lens investing, which is the integration of gender analysis with financial analysis to be able to make better investment decision. And in the context of defining an investment strategy, the gender analysis can include making money available to enterprises owned by women, ensuring that these funds are also available in healthcare facilities, because we have seen that 75% of the healthcare workforce are women, and also focusing on workplace equity and employment opportunities, and investing in products and services that benefit women and girls.
Doris, can you hear us?
What are we looking at? What is the action that is needed right now? Recently, we had the Global Progress Report that was launched last year, which I was part of. And
Doris, can you hear us?
That we
Okay. Because of time,
sorry, can you hear me?
Yes, we are asking you to summarize in 2 minutes because of time.
Okay, this is my last slide. Can I continue?
Yes, continue.
Okay, I'll take a minute.
Yeah, you take a minute to summarize.
We need to develop. So sorry. We need to develop the capacities of health workforce, including women. We need to ensure that we monitor and review progress of water, sanitation, and hygiene in healthcare facilities, and include indicators to monitor gender equality. And we need to integrate water, sanitation, and hygiene into regular healthcare sector planning, budgeting, and programming, and to have discussions like we are having right now moving forward. So thank you so much. I'm not going to present all the slides. I think I had 2 more remaining because of time, but thank you so much for the opportunity to share with you this today. And I've also shared the slides with conveners to be able to share with you all after this conference. Thank you so much, and over to you.
Okay, thank you very much, Doris, for that very informative presentation about WASH and how it affects women. So I don't know. There's a problem with the sound system. I don't know, Doris, you can wait for the other 2 presentations so that we can have a session of question and answer. Doris, you're still there. Okay. As we wait for
I am still here, and apologies once again for the technical glitch. I hope can hear me?
Yes, we can hear you. Are you able to stick around for the question and answer session after all the presenters have done their presentation? Okay, we have not received her response, but in the meantime, we can go to the next presenter, who is going to be Dorcas Amakobe, the executive director of the Moving Goalpost, to make up her to give her presentation, and she's also going to be online. So, Dorcas, we have given you 10 minutes because we are far much behind schedule. Thank you. So, is the presenter online? ICT. Okay. Yes, Doris. You can give your presentation. Please keep to the 10 minutes because you are far much behind our scheduled time. Thank you and welcome.
This year, the African Leadership University embarked on the second cohort of the Silicon.
No, I can't hear you. I'm not sure if you
Doris,
can hear me.
Yes, we can hear you. Go ahead and make your presentation. Go ahead. You have 10 minutes.
We can hear.
Yes, we can hear you very well. Go ahead. Doris, you seem to be muted. That's what I'm being told. Yes, go ahead and give your presentation, Dorcas. Dorcas, go ahead and give your presentation.
Thank you.
Yeah, for 10 minutes.
I've just heard you now. I was unable to hear you.
Sorry, we are muted.
Good afternoon, everyone.
Good afternoon to
My
you.
name is Dorcas Amakobe. I am the executive director of Moving the to be played before I could start to give my submissions. I'm not sure if that is possible.
Yes, Dorcas, how long is your video?
3 minutes, 3 to 5 minutes.
Because the whole presentation, we have given you 10 minutes. So if you can do the 3 minutes video, you take 7 minutes to give your presentation.
Yes, I'll do that.
Okay, thank you.
Okay, great. No worries. So I will continue. I've just learned that. Okay, let me try on my end.
You have the video yourself from your end.
Sorry, let me just proceed. I'm unable to do that.
That's okay. Then you can do
from
it in 10
my
minutes.
end, because I feel like if I start doing that, it will take a lot of my time.
Okay, just go ahead.
So I just want to first introduce the subject of sport and sport for development as an opportunity for economic empowerment and mental health well-being. From where we sit, I'm sure for everyone in the room, we try to engage in a lot of movement.
For the sake of time, we can pause her. If she gets back online, we'll tell her to make a presentation. But now we can go and we can go ahead and get Dr. Oteo's presentation as we wait for their online connection to stabilize. Thank you, Dr. Oteo.
If you participate in to report incidences of abuse, and also how they can be in a position to really communicate to their parents their requirements, I would say, in terms of their sexual, reproductive, and health and rights. So currently we work with about 8,000 adolescent girls and young women who, as much as they get an opportunity to play sport, they also get an opportunity to lead the sport. Within the communities that we work with in the coastal region, girls become leaders in these spaces. Girls find an opportunity to also take up sporting opportunities as professional careers. In our communities, what we have seen so far, we can say that 44% of girls who've been part of our program see an opportunity of gaining from sport as in itself as an economic opportunity, and 58% are able to actually access other opportunities that come with participating in our program. I would say, for example, we provide opportunities such as girls becoming coaches, girls becoming referees, girls becoming football administrators, girls becoming, I would say, reproductive health educators. And this, in a way, inculcates the culture of girls seeing opportunities, especially for their career advancement, and also for an opportunity for income generation. So beyond just like using sport in itself to provide an opportunity, we also have intentionally integrated an economic empowerment program whereby we provide opportunities for girls to learn about entrepreneurship. So they are able to engage in income generating activities. They're also able to start their own businesses and start saving. So one thing that I want just to share as a story is that when we ask our girls our questions of how are you able to confidently use the resources that you really generate from your businesses, I think the biggest challenge that we still have is that girls do not have the autonomy to use the financial resources in a way, especially the ones who are between 18 and 25, in the way they want, especially because of the cultural and traditional practices within their communities whereby other people make decisions for them. When we started our project with the girls, one of the things that we try to integrate is girls learning the savings culture and also teaching girls about their financial independence. So at the end of the project, we are able to see that the girls who participate in our program who play soccer are now reporting that I would say a good percentage of around 60% are reporting that now they have autonomy over their financial resources because earning an income and not being able to make decisions on that income can also be a challenge. So we use our programs in a way that educates or teaches the girls that yes, they have the resource of sport, yes, they have the resource of other opportunities that come within their communities, and therefore they find a way for them to actually prove to their communities that girls should not only play traditional roles that are allocated to them, but girls actually can be able to take on additional roles just beyond household chores. So we are using sport in a way that communicates directly, like the girls are doing it, they're playing soccer, they're wearing shorts, they are, being referees on the pitch, they're center referees, they're linesmen, they're running businesses. And this in itself helps us to really communicate to our communities the position that girls can actually do more things beyond the traditional roles. And therefore we need to invest resources, we need to invest support for girls. And just to add on, like we don't do this in isolation. So we work with the parents. Parents are our biggest stakeholders. Schools are our biggest stakeholders. I'm really glad that my CEC has just spoken before me. The county government of Kilifi, Jumuiya ya County ya Pwani are our biggest stakeholders. And they really help us to be able to see what are the opportunities that in terms of policy, what are the opportunities in terms of supporting girls that we need to enhance in terms of the frameworks that support our objectives or the work that we are doing with adolescent girls. So that's from me is a brief of what we do at Moving the Goalpost. I wish I could have shown you the video, but I hope as part of the report of the conference, the conveners will be able to share with you the video so that you can watch. The video is on YouTube. Thank you so much.
Can we give a hand of applause to the presenter, Dorcas Amakobe? Very moving presentation about how we can turn sports into economic activity, of which it is, but at community level, and especially for economic empowerment of girls in the communities. Our last presentation for this session is going to come from Dr. John Otel, who is a lecturer at the Department of Psychology here at KU.
You are on mute.
I'm on mute. It's okay. It's okay. It's okay. Yes, Dr. Otel, welcome.
Thank you so much, Dr. Sami. Okay. Yeah, thank you so much for the opportunity to present. I'm presenting from a point of disadvantage, being the last one. Much of it has been said, but it is also an opportunity that I could be able to echo to what my colleagues have said. So, as I was listening to Ruth, that's why I wanted to modify my presentation, echoed to what I'd already heard, especially when she said that they've been involved in trying to plague the 4 S's. That is silence, self-blame, shame, and stigma. In other words, as we are planning or doing the women economic empowerment, we need to deal with the negative us. What are usually negative us, where we regard especially people in disadvantaged positions. Could it be women or men, but now we are talking about the women. Could it be the inmates, could it be the SUDs, could it be the refugees? Sometimes we look at them as useless, silly, they suffer in silence. Sometimes they have self-blame, they suffer from shame and stigma, which is a negative us. How can we change that into a positive us, whereby we need to shape up by recognizing their problem? We go an extra mile. In other words, we stand out, we go an extra mile, speak for them, assist them to seek help, and support them. Please, my presentation. So then came Doris, where she was talking about the quality of, very interesting, that the health is cheaper than the health care. And she really tried to echo the aspect of the dimensions of wellness. Of course, as much as we are talking about safety, water, environment, which is more of a physical dimension, we are aware that the dimensions of wellness are interdependent and they are interacting. So inevitably, for example, when a person doesn't have water or has indecent or unclean water, the person will feel ill or the loved one will feel ill. By extension, it affects their mental health. So coming to Dorcas, she talked about one thing that was stuck behind her back was the celebratory awards, and she talked about the power of soccer as an opportunity for the women economic empowerment and mental health. In fact, in psychology, we have what we call expressive and art therapy in mental health promotion. I want to share with you that this year mental health awareness promotion that we actively participated, where I was the coordinator. Our theme was movement, moving more for mental health. And she really brought it out how they are engaged in sport, but at the same time promoting health generally, especially the sexual and reproductive matters. What remains for me? This is my title. The Mental Health and Women Economic Empowerment Strange Bedfellows, or bedmate fellows. From the onset, I have to apologize, friends, because I'm trying to trivialize a very serious discourse into things of bedroom and bed mothers. But I thought that's the best way I can summarize the interface between mental health and the women economic empowerment. Basically, because at the survey's value, please next slide, at the survey's value, when you look at the definitions, and I'm not telling you to climb them because I also copy-pasted them from wherever I found them, at the face value, these are strangers because you look at the wording and everything that is there, they are strangers. But when you do a deep analysis, next slide, you'll find that the ingredients that the women economic empowerment is made of and the mental health, in one way or another, they are related. Because when we are talking about the women economic empowerment, we talk about the power and agency. That is, women have the power to make informed financial decisions. They have the power to access resources and, of course, advance their lives. But when you look also at the mental health, there's a lot of that control. There's a lot of that power when we look keenly on the key ingredients of what mental health is all about. Hence, I'm saying, the bedmates, husband and wife, I don't know how you can call it. Next. Now, how can we explain this? This one I also borrowed. Kemod was trying to check on the relationship between very many components. Remember, like Doris was talking about the physical health, so much on the physical health. But as we said, the dimensions of wellness are interacting and interrelated, such that whatever that happens on the mental health improves, you can see the arrow, the physical health. And when somebody is in the good health, that means that person is able to work, that person is able to do business, that person is able to participate in any productive work. And that makes that person to be empowered. Equally, when the person is empowered and he advances economically, that means even his financial stability and the power is better than it's working. This is a villager. Go to the slide where we were, the diagram. This one is confusing me. I'm a typical village and the big city. So I will be telling you where the arrows are. Okay? So you can see there's a relation between improved health, mental health, and the physical health. The same way, when somebody is physically okay, there's that satisfaction and there's that happiness that comes. So it influences the mental health. And when somebody is okay, physically and mentally, obviously we engage in productive activities and enhancing his economic empowerment. And especially the woman that we are talking about. And when somebody is economically empowered, it improves his competency, it improves his self-reliance, and the self-esteem, which are constructs of mental health. So our argument is this. The socio-economic interventions, when they embrace the mental health or the physical health, is like killing two birds with one stone. So, next. So, what are we saying? What are we saying? When you have an intervention that embraces women economic empowerment and mental health, because one characteristics, please do before the slide, before this one characteristics that we are going to get about this relationship is reciprocal. Women economic empowerment influences mental health influences women economic empowerment. It could be poor mental health disempowers a woman, or a good health, vice versa. Or poor or disempowered woman is affected in his mental health. But how can we explain that? There are many possibilities. Poor mental health or good mental health leads to women economic empowerment. Or the women economic empowerment leads to good health. But at the same time, next slide, it could be both of them, they share a common causal pathway. So that if you focus on an intervention that focuses on those common causal pathways, is what I say, using one stone, but killing two birds. Next. Next, please. Is there a beacon of hope? Oh, yes. I want to quote one of the great monks from India who says, the best thermometer to the progress of the nation, it is the treatment of the women. If you went to the previous slide, please, my brother, go back. There's something I'm explaining. You'll find that women are twice likely to develop depression, post-traumatic stress disorder, anxiety disorder than men. Basically because of those causal pathways. Poverty is a risk factor to poor mental health. And 70% of the world poor are the women, unfortunately. Then, even the working class women, there are factors that work against them. For example, low psychological safety. What is psychological safety? It was shared this yesterday. Psychological safety is the ability to take risks. Such that if you dare and take risks, you have a higher psychological safety. But you may find that women in their places of work, sometimes they don't take that risk. Either there are double standards for a woman, Either there are stereotypes for that woman, there is the aspect of work-life balance at home that I want to sacrifice for my children. I do not want any promotion. I don't want to be a chair of a department because I would be called meetings anytime and I want to take care of my children. I'm still young. Right? That affects the psychological safety of the person. And because of that work-life balance, chances of burnout, women are more likely to suffer from burnout than the men because of the work-life balance. I think it was shared here. Then the aspect of the imposter syndrome. What do we mean by imposter syndrome? Imposter syndrome is that feeling you have, even when you are qualified, you feel you are a bit inadequate to take that particular position. Because of the stereotypes. Who am I as a woman to lead a group of men? So those work-related, they can lead to either economic empowerment or disempowerment or the mental health that we are talking about. Next, my brother, as I finish. I'm finishing. So what are we saying? There's a beacon of hope in investing in the treatment of a woman. It's the best thermometer. I've been convinced. I'm working with an organization as a consultant. And unfortunately, my brother here is analyzing our work. The effectiveness of problem management plus on the quality of life of women living with the fistula. What we have realized is there are women who go through the treatment as usual, where they go for surgery and they're left there. But if you combine that with psycho-education plus vocational training, their quality of life is different from those who go through the treatment as usual. My brother, I need the results. And the advantage for women is when a woman is mentally well, he affects himself or herself, their families, and the general populace. We've been told 75% of the women are in the healthcare workers. So, another advantage women have is they tend to have better social networks than men, easy to confide with their friends, and they are more likely to seek treatment for mental health. The only barrier for them is when they are not economically empowered. Let me tell you, for the men, when you see a man going for a tooth to be taken away, that mzee has really suffered. But for the ladies, they go very fast, timely interventions, we are told, and they do well. Next. What is our way forward? Lastly, I think our first presenter talked about it. Individual self-care plan. The ladies in the house, the men in the house, it has to begin with you. Yesterday was Self-Care International Day. And this is the Self-Care International Month. Please think about it. Having an individualized plan about your self-care. It has to begin with self-love. Because I'm a Christian. I'm sure it is there in the Muslims. Love yourself as you love your neighbor. You can't give what you don't have. Good friends. So it has to begin with you. It was also pointed out by our keynote address speaker that holistic interventions, and especially I'm supporting where we have gender empowerment plus mental health. You combine them, the outcomes are more likely to be better. In our workplaces, how do we increase women-friendly mental health in the workplace services? If you go to most rehabilitation centers, you find that they don't have women-friendly provisions because I can be having SUD, substance use disorder, but I'm having a baby. Is there a provision that when I go for that service, there's a provision that they will be taking care of my baby somewhere? Especially when I go for inpatient programs, you may find that it may not be there. So the fact that there are more men in the rehab centers does not mean that women are not suffering from substance use disorders. The facilities themselves are not women friendly. Leveraging on technology. I was so happy. I wish I was having this slide because I was improving on it. Look at the helpline that we were being given by our speaker. speaker, the first speaker. How can we leverage on women economic empowerment at the same time about mental health? How can we improve the psychological safety enhancement programs such that we can counteract the stereotyping, the negative evaluations, double standards, lack of support, and undermining for the women in the profession? A woman gets a promotion, but you could hear people talking in low tones. Perhaps he may have used other powers. And that's a qualified woman. Very unfortunate. Those are the stereotypes that we are talking about. But I'm happy in Kenyatta University. Our CEO, a woman. The director here, a woman. We need a clap for that. Kenyatta University, we are doing well. The financial literacy. There is a close, next my brother, there is a close relationship between financial stability and mental health. Let me tell you, when you are having some money in your pocket, even the walking gait changes. And when you are in debt, the facial expression can show who you are. So what are we saying? Women economic empowerment does not mean how much money a woman or a man has. What is your relationship between you and the money? That is the most important thing. You could be having $1 million, but you are in debt. I saw one member of parliament. Members of parliament, they earn 800,000. But I saw one member of parliament who advertised his sleep and is earning around less than 20,000, but is earning 800,000. You give to John Samson Hotel, my friend, my walking gait will change. That is in my view. But when I reach there, perhaps my relationship with money, especially on my debt behavior, could be affecting my mental well-being. So what is this can we do to empower a woman in terms of their relationship with the money, in terms of saving, in terms of investment, and in terms of debt management, especially from informal debtors, where the profit margin for them is very high. And unfortunately, some analysis was done. Women are victims for informal debts than the formal ones, the bank and that stuff. And there are very many reasons for that, whereby the interest is very high. And when the interest is very high, what happens? Still the woman is disempowered. So, my brother, I stop there.
Very powerful, Dr. Oteo. We did know that there's that nexus between empowerment and health. And you made your presentation and you made it very clear that empowerment is in fact very important. So because we don't have time, I think I'm going to ask the ICT to run the video that was to be presented by Dorcas. It's just a 4-minute video. Then after that, we're going to take 2 questions from the audience and we close the session. ICT, you can the video. Thank you.
I'm in Bale, Ganze Sub-County in Kilifi, and I want to talk about a program that takes people from pain to power. And this is one example. Lilian Sasa. Tumekutembelea leo kwa biashara. Yeah. Lillian's story is born out of what I've said, from pain to power. She learned about moving the goalpost program at a young age. But because they equip you with the tools to navigate sexual reproductive health and rights, learn about gender-based violence, economic empowerment, there's a huge pain point around teen pregnancy, not just in Kilifi, but in many other counties. Lillian fell pregnant, but not all hope was lost. She was able to get back and learn skills on how to start a business. And that's what we have here today. Is her business that's allowing her to support her newborn and her family. And that is essentially the importance of programs like Moving the Goalpost, tying together the needs of the community, skill sets that can be learned, and eventually raising a generation of people who can take back their power and make something.
Naitwa Lilian Mahenzo. Hiyo ujauzito ilinipata nikiwa form 4 yani. Si nilikuwa najitia kama ujuaji, hata kama kuambiwa hivi usifanye hivi. Sasa kule kujifanya uwe uko na pesa kama wengine unatamani. Mwana msichana fulani amevaa nguo nzuri, ile naipenda. Alafu nikimwambia mamangu nasema ana pesa. Sasa nitaipata wapi? Wajifanya fanya napata huyu mvulana. Nakupa kama ni 500 ama 100 ngapi, na nakupa. Nanunua na wewe kesho najiona umevaa na ringa barabarani. Ndio hivyo tayari. Kadanganyika hapo katikati. Sikuelewa kama ilienda vipi. Kapata ujauzito. Nilishtuka. Kamwambia mamangu sasa. Alikuwa mkali mara ya kwanza, akamuelezea huyo babangu. Na babangu alikuwa mkali. Afu ile hasira ikamtoka. Mpaka sasa hivi tunaishi.
During COVID, we had an increase in teenage pregnancy, and Kilifi County was not an exception in that. And Moving the Goalposts, with support from Amplify Change, started a project called Bint Nawiri. In 9 support groups. Once these teen moms meet, they get sexual reproductive health and rights education, psychosocial support. They also get information on contraceptives so that they don't get a baby number 2. We also ensure that they get entrepreneurial skills so that some of them can start businesses. We also ensure that those who want to go back to school are supported to go back to school.
Mwanzo tulifundisha kuhusu mambo na kulea yule mtoto, biashara, kuna kuweka records, ujue je napata faida ama naingia loss. Kwa siku hapa huwa naweza pata kama 3,000 ama hata zaidi. Naangalia tu vitunguu kuna ndogo shilingi 5, shilingi 10. Hivyo pole mpaka saa hii nimefika hapa.
Out of the 252, 56 of them have gone back to school, and 30 have started businesses. We have table banking that happens, so we have saving groups within the teen moms.
Naweza kushauri wengine hivi kama walipata mimba kama mimi, wangeshika biashara. Ningependa yani wasikae nyumbani. Yule mtoto anataka nguo, anataka kula, anataka kunywa. Wewe mwenyewe unataka kuvaa. Ukishika biashara inakusaidia.
My call to action is even for other partners, work together and collaborate and have holistic programs just like MTG does to try and reduce the teenage pregnancy in Kilifi.
Thank you very much. That's a very informative video about how the county partnered with some organizations to empower girls who had teenage pregnancies during the time of COVID. Because I know we have run out of time, I'm going to invite only 2 questions, and I'm hoping our online presenters are still there. Ruth, Doris, and Dorcas, are you still there? And also our presenter here, Dr. Hotel. So audience, let's take just 2 questions so that we can have time for the remaining sessions. Yes, Dr. Hilda Mahamara.
Yeah, my question is going to the Dr. Masha. She indicated that when they came into office, the UN women came and trained the CECs on gender budgeting, gender responsive budgeting. I wanted to find out from that training, what can she say is the percentage of that has been allocated to women or the gender office in Kilifi?
Okay, thank you very much. That's a very good gender responsive budgeting at the county level. We have Professor Onywere here with a question.
This is to the lady of WASH. I was wondering, for a long time we have seen that most cities, towns, and areas where water supply is given, there's a relationship between water supply and sanitation. And actually the connection, the terminologies or whatever is used is in that context, water supply and sanitation. And the water supply, we pay for it. And it's assumed that within that amount of money is an amount of money for sanitation, for wastewater management. But then we realized that in all our systems, there's a low prioritization of wastewater management systems. So that is not part of the plan of even development. Water supply may be that. How do we expect to achieve then the sustainable goal needs for WASH when we have very low priority on sanitation? It's not part of our development planning.
Very good question on WASH. And maybe we can take one final question. If someone has a very burning question, then we can allow our presenters to respond to those questions. Yes, we have one at the corner. And this is a very last question. And I'm sure we'll have an opportunity to interact with the presenters later on. Thank you. Go ahead.
Thank you very much. My name is Okumba Meruka. My question is to Dr. Teo. You made a very interesting statement that women's economic empowerment is not about the amount of women a woman has, but the relationship that she has with that money. Is that not a truism that would apply even to men? And in your study, what do you find to be new about that statement? And what are the other variables that then determine women's economic empowerment? Thank you.
Okay, thank you very much for that question on the relationship between empowerment, women economic empowerment, and health. I think we are going to go to get the responses in the order which the questions were asked. So I'm going to ask Dr. Masha from Kilifi County, if you're still online, to respond to that question on gender responsive budgeting.
Thank you so much for the question. So what we basically did, because again, we need to empower our women, both economically and socially. The UN women were able to talk to the various CCs members that were present on mostly the ACPO, because again, you have to do 30% of for each budget, each department. There's an ACPO for women and an ACPO for youth, sorry. So you're supposed to, each department is supposed to say how many activities or how many jobs or how many youth or women have they trained or empowered using those ACPO, like when they're coming for tenders, how many people have benefited, how many women. So basically, I cannot say how much the percentage, but that is the approach they used during the training. And in my department, we were doing the performance contract, and at least we were able to show that through the Wezesha Fund in the Department of Trade, we've been able to at least economically empower women by at least 30% from the various people who have taken jobs through the Wezesha Fund, where it's a revolving fund. Women come and take a loan, they do the business, we're able to market and demarcate and see how many women per ward have been empowered. So that is how we're able to empower them, and that's how the training helped the CC. Thank you.
Thank you very much for your response. And we can go now to the next next question. That was on WASH. With us, she had indicated that she might be leaving for another meeting. So ICT, can you confirm if she's there? Doris. Okay. Because she's not there, we can go to the next question. That's Dr. Oteo. Respond.
Yeah, thank you so much for that comment that it is tourism even to men. I want to give one empirical example and then one practical example that happened to me. As I said, especially the death behavior of women and men differ in a way. Especially you find that because of other factors, women are more likely to hold informal debtors who charge high interest than the formal debtors, like the bank. You find that a Mama Mboga has borrowed 1,000 and is supposed to return it by a day by 100. Multiply that by 30. But for a man, perhaps of other factors, either they are working or they're in a formal job, they will get the credit from a formal arrangement where we are talking about 12%. But if you calculate that percentage for those who are in accounts, you see, if you calculate the woman who's returning 100 per day, and if you owes that person for a long time, you can imagine how much is returning. That is one factor that brings the gender differential, especially on the debt behavior. Another aspect is the aspect of saving. I'm not saying that men don't save, but I want to give this what I will give you with a practical example. When I was registering for my PhD, before I got a scholarship, I went for a top-up. My principal, we went to the PhD class the same time, but she did it in such a way that she had around 3-4 jamas. And September, when we were going to campus, the jamas were in such a way that she was the last person to receive, and they happened in September. Who was wiser than the other? Because me, I went for a top-up. My loan began from where it was. So you find that if we get a female and a male in terms of the gender differential, in terms of the saving behavior, that can explain for itself. So it is true that the relationship between a person and money is very key in empowerment and mental health, but we have gender differentials between men and women. That's my take.
Okay, thank you very much for that response, Dr. Oteo. And I think that has brought us now to the end of this session. And we want to thank the 4 presenters who made their presentations on women, economic empowerment, well-being, and health. And want to appreciate and encourage the participants. If you had a question and you didn't get to ask, it's because of time, but you can still engage with the presenters later on. So at this point, I want us to applaud all the 4 presenters as we invite the moderator of the day to carry on. Thank you very much. Let's applaud the 4 presenters. Thank you very much.
Thank you. We want to thank the chair of the session, Dr. Samuel Mwangi, for chairing the session in a very, it had challenges here and there, internet, but we have made it. Now we want to split for the next session, where the people who are supposed to be in group B I will need you to move and move very fast, which the group B is where you were yesterday. And Dr. Esther Kashara, I hope you are with your group, so you have to move with them. And group A, Dr. Edna Thango, you will remain here. And we will want to, even the ones that will be moving to group B, please make your sessions to be more faster so that we don't leave late. When you are told to do the presentation and you are given 10 minutes, you know your presentation very well. Don't go into details. Tell us what we want to hear. Be brief and to the point so that we can be able to get the gist of your presentation. Like that, because if you drag us, sometimes now we will lose the balance of listening to you. But if you are brief and to the point, then we will be able to get to grasp your presentation, what it is. So can I have the group B leaving my room to go to the other room? Dr. Kashara with your group. And Dr. Edna Thangu, you will take the chairmanship or chair ladyship of this session. So you can come over. The moderators of Group B is Ruth and Benta Mukami, and the moderators of Group A, which is here, is Nancy Kishuru and Nyanchoga. Who are supposed to be in Group B, I think I want to have Peter Kithinji, Dr. Pacifica, and Maruta Kirema. You go to Group B. Maruta, Dr. Pacifica, and Peter Kithinji, they are moving to Group B. And then Group A, we have Keith Obiero. Then we have Muika Mwaura, that is Lucy Maina, Miruka. Then we have Mutuota, we have Professor Grace Ngare, and Judy Gina, who are supposed to be presenters here.
Thank you very much. Is it good evening or good afternoon? So as you've heard, I'm Edna Thangu, and I'll be working with the rapporteurs, as you've heard, Nancy and Sylvia Nyanchoka. So our first presenter is Keith Obiero from CFK Africa. As you've heard, you have 10 minutes so that we don't take too much time. Welcome. I hope the rest of the presenters have sent their presentations so that we don't have too much time changing over. Karibu.
Good afternoon. Correction, I'm not Keith Obiero. My name is Mediatrix Tuju from CFK. Should I start or I wait for you to project? Now, to tell you a bit about CFK, CFK is a leading non-governmental organization headquartered in Kibera, and it has been around for over 20 years. We work in 25 other informal settlements across 8 counties in Kenya. And we exist to fight extreme poverty in informal settlements through complementary youth leadership and health initiatives. So our focus is largely on the youth because of the youth badge and the challenges that the youth face. I started before giving you the title. So the title of our work is Effectiveness of CFK Africa's Girls Empowerment Program in Enhancing Women's Economic Status in Kibera, Nairobi City County. Since establishing the first girls-only soccer initiative in 2002, CFK as an organization has been able to pioneer other soccer initiatives across Kenya with the aim of promoting community cooperation and development, connecting girls to health facilities, and to build valuable life skills for girls to become active leaders in their communities and increase economic opportunities. We do this through the health facilities that we have in the informal settlements and which charge affordable prices, hence encouraging health-seeking behavior to the girls, to the young women, and to the community at large. A bit of background about this project. The population of the informal settlements is estimated at 60%. That is according to UN Habitat 2016. So this is a big proportion of the population of Kenya that live in informal settlements. And majority of this population is the women and girls. The informal settlements are characterized by high levels of poverty, inadequate infrastructure, and also they have limited access to education and health care. So the women living in slums and marginalized area also face additional vulnerabilities, which include high teenage pregnancies, early marriages, inequitable access to sexual and reproductive health, and poverty is the main contributing factor to these challenges which they face. Through our programs, we implement activities with the girls and young women that are able to address some of the challenges that they face. For example, we have a Funzo project which targets teenage mothers in Kibera and other informal settlements in Nairobi like Mukuru kwa Njenga, Mukuru kwa Ruben, Viwandani, and Mathare. What we do is to reassess and re-enroll the girls back to school so that we give them a second lease of life. We also take care of their children because it can also be daunting to young mothers being in school and they do not know the status of their children back at home. So the children are taken to daycares so that they can concentrate fully when they are in class. And the good thing is that these girls are doing so well in school, even beating the girls who have not become mothers. In terms of sexual and reproductive health, we also have trainings and mentorship programs for them. The barriers that I have mentioned limit women's and girls' access to transformative power, which can build confidence, leadership skills, and also unlock educational and economic opportunities. Again, through the projects which we run, we are able to address this because we offer capacity building sessions to these girls. We have mentorship sessions for the girls, And also, we also have MHM, that is menstrual hygiene lab, to take care of these girls' issues. We operate on a theory of change which is largely locally led. That as CFK, we give them the power to implement with our support. So like the mentorship program which I have mentioned, the girls are trained and they are given the powers now to be able to mentor the other girls within the safe spaces that we have created for them in schools and at the community level, and also cascade that to the community. So that means we are not leaving any girl behind. We are using the girls to be able to uplift the other girls at the community level. For the athletes, the girls athletes, there's a study done by Winter et al. In 2023 who noted that girls also face additional challenges, especially the athletic girls, like the girls in sports, so like soccer, due to access to lack of proper training, considering the spaces where they occupy, and also lack of equipment to necessitate valuable training for them. They also suffer from social stigmatization and limited resources, both for themselves and for their families. So CFK Sports for Development. CFK runs Kenya's worldwide community football for children, for young girls and also boys between the ages of 11 and 17. This project has been dubbed VBS, that is value-based sports. And it is done in Nairobi, Kisumu, Nakuru, and in Mombasa, with the intention of developing morality among the boys and the girls in the informal settlements so that they live positively within their spaces. And it also provides an avenue where they are able to discuss the challenges that face them. We also have another club, that is the Kibera Soccer Football Club. This is an only girls football club who also participate at the national level. And through their platform, we advocate for social change and also empowerment of the girls. The beautiful thing with the projects that we operate or we implement is that each of the projects feed into each other. So they are not implemented in isolation. And a girl or a young woman participating in one project would benefit from all the other projects that we implement. Because of a challenge of time, I may not mention all of them. The research objectives we had are two. That is to assess whether CFK Africa soccer initiatives are effective in promoting holistic girls' empowerment, particularly in areas of social, sexual and reproductive health, individual agency, and also capacity building, and examining the role of sports in providing socioeconomic opportunities for young women. I'll go to the key findings. One of the key findings is that the Kibera Women's Soccer Project is a valuable model of development that can be replicated in informal settlements. And also soccer initiatives play a crucial role in education and economic empowerment, having mentioned part of those projects which we implement, and inspire positive social change for girls in Kibera, offering them a platform to build resilience, leadership qualities, and economic empowerment. I may skip methodology and just quickly move on. The study we did has limitations, and this include the young women. The study only involved the young women who are participating in soccer. So that means that it did not go into the depth to be able to provide holistically how economic empowerment comes out in this. And then secondly, also we had very few key informants who were involved in the study, and therefore it may not have been robust as it should have been. Some of the key findings from the focus group discussions that we had was that the girls had developed confidence, which they did not have before participating in the football club, that they are able now to speak out, they are able to stand up for the vulnerable in the society. So it means that they become protective and are able to engage so that every girl's right is observed at the community level. The other finding is that they have developed valuable skills to enhance their personal growth and reproductive health, and also economic empowerment. What CFK does in terms of economic empowerment is to pay the girls a stipend at the end of every month. So this money which they are given helps them to take care of their other needs at the community level. And the findings also indicated that the money they are given does not only benefit them, but also their families at the household level. So it means that the money they are getting has given them power to be able to actively engage in this space and be able to deal with issues which they would have otherwise not have done so. I want to give quotations from the girls on how participating in CFK soccer has been able to improve on their economic status. For example, one girl, and I quote her verbatim, "I was paid 35,000 shillings and I used this money to build for my grandmother a house. She did not have a house before because her house was leaking." There's another one who said that after the passing on of their dad, their mother became so affected by grief, and she had to step in as the breadwinner of the family to take care of the other siblings. Others have already started investing, and one indicated that through her payments, she has bought a motorbike, which now earns her daily income of 300 shillings. Others are using this money to take care of the health of the extended family members at the community level. To conclude, this paper recommends continued support and investment in soccer programs for girls, as these promote sexual and reproductive health and enhance social inclusion, well-being, and economic empowerment for young women in informal settlements like Kibera. The other recommendation is with accessible and relatively low barrier to entry, to implement soccer programs in communities experiencing extreme poverty. This paper strongly recommends continued funding, support to meaningfully improve the lives of young women and enhance their economic opportunities. And lastly, as CFK Sports for Development program continues to evolve, it holds great potential to further empower young girls and contribute to their holistic development. Thank you.
Thank you very much, Mediatrix, for that wonderful presentation. For me, it was music to my ears because I belong in sports. So be sure I'll be talking to you after this, and also for bringing sports in women empowerment. It's such a great tool as we had from the rest. So thank you very much. So kindly allow us to have all the presentations first before we ask questions. So the next presenter is Miruka. Kindly, the stage is yours. Thank you. I somehow favored her, added 3 minutes. Let's go back to the rules. Anyway.
Good evening. Is it good evening or good afternoon? Whatever it is. Yeah. Miruka. I'm a member of the KU Rehab SGBV team. But I want to say currently I teach at Southeastern Kenya University in Kutv in the Gender and Development Studies section of Sociology, Anthropology, and Community Development Department. Now, this presentation was to be made by Professor Lucy Maina, but she's not in here. So in the spirit of teamwork, I'm doing it on behalf of the team. The paper is about qualitative assessment of transformative change in lives of GBV survivors using evidence from stories of most significant change. Now, this is part of a wider study that was looking at the effectiveness of state and non-state interventions on the recovery of GBV survivors. And we focused on two interventions. One, Makueni Gender-Based Violence Recovery Center in Wote. And then the other one was Lifebloom Services International, which is a non-state actor based in Naivasha. So there were three products to this so far. One was a paper on the effectiveness of these interventions. The other was on the cost of gender-based violence. And then this third one is now looking at the information that we get from the stories of most significant change. Now, the stories of most significant change technique is a qualitative method that you use to assess impact of an intervention. It has become pretty popular now in terms of seeing the changes that have occurred in people's lives. Not just changes, but the changes that they consider to be most significant. So it has a number of steps that you go through with them to capture these stories and then to analyze them. You do not have any pre-selected indicators, but you allow them to emerge as the stories are told. So it's basically a free rein for people to tell their story about where they were before they entered intervention, where the intervention took them, and where they currently are, and to map what in their own words and in their own view are the most significant changes that they can attribute to the intervention. Now, we collected 6 stories from SGBV survivors. Most of these stories were from women who were who used to be in commercial sex work. And before joining commercial sex work, they faced a lot of abuse, gender-based violence, from their intimate partners, principally their boyfriends and their husbands. Some were married, their marriages broke down, so they had to look for alternatives, and most of them therefore joined commercial sex work. Now, the abuse did not stop when they joined commercial sex work. It continued, and it manifested in different ways: physical battery by their clients, non-payment for services, clients demanding to have the services without prophylactic, protection, emotional abuse, threats, intimidation, and so on and so forth. So a lot of these women, basically moved from the frying pan into the fire. And going through this, they then ended up with these interventions, either through introduction by friends or the proactivity of those interventions themselves, looking for women who needed this kind of assistance. So we talked to them to see what did they go through in these interventions and how has that transformed their lives. Now, The stories, we have 6 stories, but I'm not going to go through each of them. Let me just read one to give you a sample of what we are talking about. Sabina grew up as an orphan who barely completed primary school. By 19, she was already married to an abusive husband and had 2 children and a third one on the way. Her life was characterized by unending episodes of violence. She was introduced to Life Bloom International by a friend. While here, she received counseling and was trained as a caterer. She later joined a peer counselors group and undertook paralegal courses, enabling her to join the center on full-time basis, which therefore improved her income. Over time, this enabled her to invest in land and houses and provide good care and good quality education for her children. She is now considered a role model in her community and assists women who have undergone violence to get back on their feet. That's just one of the stories, and we have 5 others. Now, when we look at these stories, we tease out a number of messages that come out, and that's what I'm going to talk to you about. One of the messages is that when survivors receive trauma care and counseling, they begin to heal. They become empowered, and they gain a sense of control over their lives. This was a thread that was running through each of these 6 stories. So the key thing there is about psychosocial support, psychosocial care that helps them, first of all, to come to terms with what they are, to take a back seat and look at where they have come from, and to just calm down and, depart from the source of affliction. Then 2, healing from trauma, self-determination, and development of resilience are key indicators of efficiency in interventions. This is basically about what the interventions did to them. It helped them to heal emotionally. In some cases, it helped them to even heal physically, because like in Makueni, they had to go to hospital to be treated for the injuries they sustained from the violence. But even at LBSI, they had to go for medical checkups and so on and so forth. In the process, they were sensitized and socialized on determining their destiny themselves, because a lot of them were dependent on the abusive clients and on the abusive partners. So this was to help them see that they can live a life without those people who were abusive, and to take a bold step of accepting that and moving on into how do they do it. So that was really a major departure from where they were before. 3 was that the resilience indicates the individual's physical and mental resources. So these people have to fortify themselves and mentally and physically say, okay, what do we do next? So the process of transformation required a change of mindset, but it also even required a change of residence, physically moving from one place to another to start a new life. Not all of them had to move, from one place to another physically, but they also had to transform even where they were. We had a case in Makueni where, the woman was still living in her matrimonial home, but she had to assert herself and claim her rights within that home, so that gender power relations could be transformed. 4 is that self-discovery, acceptance, diligence are critical pathways to healing from the effects of GBV. 5, these processes lead to regaining one's capacity, getting control of oneself, and being assertive in claiming one's renewed identity and deciding that the past is gone, but the future is there before you.
When we look at this, we see that the survivors experienced different forms of GBV, which came at, not spontaneous, but came at the same time. So you had physical battery, you had emotional violence, sexual violence, and economic violence all together. Now, when they joined these interventions, they were at different stages of desperation, including suicidal, thoughts. Now, the interventions enabled them to turn the corner by giving them space to reflect about their past and present and to chart a way forward. Key in this journey is the transformation that was brought about principally by the psychosocial care that they got, but also by the encouragement that they got from these institutions, as well as the physical health care. In conclusion, therefore, we say that programs that, now this is not just about the stories of most significant change, but the study generally, that interventions that are responding or dealing with SGBV survivors should offer comprehensive care, because these people come with different needs. So one needs to assess what their specific needs are and therefore tailor the services to that. And if this care is comprehensive, then it has got a higher potential of creating a good impact on them. We also noticed that the transformation these women got was not only at the individual level. They radiated it to the community level, so there was a multiplier effect. A lot of them told us that they now could speak out against GBV. They could counsel other women. They could also direct them to go and seek the services that they themselves benefited from. In terms of recommendations, therefore, we emphasize the need to have comprehensive care, which is not just restricted to medical legal services, which tends to be the default service provided. Two, we are proposing that there's need to create linkages among different actors, governmental, private sector, and non-profit entities, so that survivors can get the range of services that they require, because not any one of those service providers can provide all of them. Three, there's need to continuously track the impacts of these programs, but also their untapped potential, so that they can be made better. A lot of them, like the non-profit one we looked at, is surviving on funding which is not very sustainable. But if we can demonstrate their impact, then it's possible that that can help them even now be linked up with government systems and government funding. And finally, we propose longitudinal studies that can trace women survivors for a longer time, so that we can see after the intervention what would be the long-term impacts on themselves and their own their own communities. Thank you very much.
Wow. Thank you very much, Miruka, for that presentation. It was so pictorial. So, yeah, we really got the story technique thing. And I'm just thinking in other areas we can do the same. Our third presenter is Mutwota Kigotho from University of New England. I'm not so sure that it's online or is here. Online. Okay, welcome, Mutwota.
Organizers of this conference. You can all hear me? Okay.
So we can hear you.
Presentation. Excellent. My presentation says, lessons learned from 3 women ex-prime ministers in Australia and New Zealand. And in a way, this is a very good segue from what we've just heard. We've been hearing about narratives, and I'll be talking about I'll be giving 3 narratives, or narratives of 3 women ex-prime ministers. And I'll go straight on with the presentation. This is just a little abstract, but I will just explain what I've put down there in the abstract. It's full of text, but it's a look at 3 prime minister, female leaders in Australia and New Zealand, their challenges, how they navigated through those challenges, and finally also establish what lessons we can learn from their experiences. But an add-on to that is that we look at their work through the lens of feminism. So I'll be looking at a few feminist theories and explaining how I would apply the experiences with those feminist theories. First question that we pose is how women, it's actually supposed to be how women and men get to leadership positions. I have a few suggestions to make. Some of them are related. The first one is people get to power through merit. Some people get to power through political expedience, and others just find themselves in the right place at the right time. And the last reason that people get to power is political backstabbing. And that last reason is important because it also underlines the fact that politics is dirty, politics is ugly, and it is challenging. But then that is not sufficient reason for people not to get into politics, because I believe that you need to be in politics, you need to be in that space if you're going to institute any change at all. And the people that we're going to be looking at today are people who have instituted changes from the position of power, from the position of being prime ministers. So, feminist theory, let's just explain this before we carry on with our narratives. And I want to say that feminism, the feminist theory is the extension of feminism into theoretical, fictional, or philosophical discourse. There are several types of feminists, and we're going to look at maybe just quick mention of 5 of them. And feminism itself aims to understand the nature of gender inequality. That is the heart of feminism theory. They don't want women to be discriminated against just because they're women. It focuses on analyzing gender inequality, looking at discrimination, objectification, especially sexual objectification, oppression, patriarchy, and stereotyping. So we have got about 5 forms of feminist theories. The first one is the liberal feminism. That is very much the traditional feminism. These are the mainstream feminists, the people who take the fight to everybody else about the need to have equality of men and women. The radical feminists argue that you need to uproot patriarchy. You need to uproot patriarchy so that we kill it, and we have equal opportunities for everyone. The third group of feminists argue that they are called Marxist and socialist feminists, and their business is, they come from the theory that Karl Marx argued that men should get remunerated work or paid work, but that's what he called the production part of feminism, and the reproduction part of feminism was unpaid work, and unpaid work was reserved for women. They did all the work without any pay. Now the fourth group is the psychoanalytic feminists, and this is very important. It's important because one of the ex-prime ministers we're going to be dealing with today, or talking about today, is one lady who got who got pregnant and gave birth while she was prime minister, so she took time off, she took maternity leave and so on. But that just tells you that although you are female, doesn't stop you from getting on with other aspects of life. We look at such people within the lens of the psychoanalytic feminism. The last group is the postmodernist feminists. And these also argue the equality for all using common structures, and not a question of just favoring women over men, but we should have total equality between men and women. So there you are. Those are the forms of feminism. I'll go on and explain just quick map here. This is Australia, the larger continent there. And New Zealand is down here. There's a small strip of land. We call these people people from across the ditch. It's about 5 hours flight from Sydney to New Zealand. There you are. Two of the prime ministers, ex-prime ministers we're going to talk about today are from New Zealand, and I'll talk about one who is from Australia. The two New Zealanders include Jacinda Ardern, Helen Clark. They are both from New Zealand, and just quick look at the kind of life they led as prime ministers and their achievements, the challenges, and what we can learn from them. Julia Gillard, like I mentioned, is from Australia, and we're also going to look at her, how she got to power and so on. So these are the images of our three ex-prime ministers. You've got Helen Clark here. Second one is Jacinda Ardern. Then is Julia Gillard. Now, Helen Clark, let's just look at, well, we start by Jacinda Ardern. Now, the biggest, the most important thing about Jacinda is that she's possibly the youngest among those three ex-prime ministers. She got to power at the tender age of 37. And when she was in power, that she got to power in 2017. And during her time in 2019, there was a terrorist attack in New Zealand. What happened here is that it was local terrorism. Somebody got into that terror mode and went and attacked a mosque, killing many people. It was mass shooting. Then quickly got into the car and drove to a second mosque, continued with the mass killing, and he was on to go to a third mosque when the police intervened and they crashed his car, and he was stopped on his way to the third station. Now, what is most significant about that terror attack is that the terrorists used Facebook to live stream the events, which was very, very traumatic to the victims. Live streaming terror, and it was possibly the first time that has happened. And Jacinda Ardern had to deal with that, and it was very, very traumatic for her as well. So that was the first challenge, and we're going to look at what she learned from that and what how she managed that problem. She also had another incident in the country. There was a volcanic eruption in one of the islands. It's called the White Island or Wataka Island, where tourists and locals were caught up in that volcanic eruption, and so many people died. The terror attack killed about 51 people. I am not very sure how many people died in the volcanic eruption, but there were quite a number too. Then there was the third major challenge, which was COVID-19, and she handled this using what is called total elimination strategy. So as far as the terrorist attack is concerned, Jacinda Ardern made two important changes. One, she introduced the law that contained the purchase of small weapons in New Zealand, and it was made law that you cannot buy some of these semi-automatics because that is what was used by the terrorists. Then she also said she doesn't want people mentioning his name ever in public. He survived and he is in jail, and he was jailed for life without ever any provision for parole. And then there was also the fact that she has started something called a call for peace, so that people are educated about the dangers of weaponizing the internet. And that is important in the kind of lessons that we learn from these prime ministers. Now, Julia Gillard, like I said, is from Australia. She got to power through what I have called political backstabbing. In Australia, politics is very interesting. People get to power through parties, and overnight you can have somebody being overthrown by a colleague. The colleague caused what we call a spill, and they're thrown out of power. So Julia Gillard got power by overthrowing somebody called Kevin Rudd, and that in itself posed very strong dangers for her because she led a very unstable government. But we also learned that Julia Gillard was a very strong, or she is a very good negotiator. And then during her time, she confronted her main opponent was with Tony Abbott. And after this, I would like you to Google the misogynist speech. The misogynist speech is where Julia Gillard gave Tony Abbott a true dressing down in Parliament. And for about 15 minutes, he was just talking about this man who is, who doesn't like me because I'm a woman. He doesn't listen to anything that I do or anything that I say just because I'm a woman. And she goes on and on and on for about 15 minutes and embarrassed Tony Abbott very, very much because of what he had done to him. But that is something that you can do a Google search on your own. Let's just talk about some of the things that she introduced, because if I give you too much stories about Julia Gillard, I'll run out of time. She introduced reforms that
Mr.
favored...
Mutwata, kindly let's be mindful of the time. Thank you.
Okay.
Yes.
She introduced changes in digital education, changes in national disability insurance, and so on. So she did have very important changes that affected both her population and the women folk. Helen Clark also introduced several changes during her time. She's the oldest of these women, and she ruled, she was in power in 1999, between 1999 and 2008. And she is well remembered for the fact that she engaged herself into so many activities, including climbing mountains and modeling what is called the World Wearable Arts Awards. That's an image of Helen Clark climbing mountains. And look at the things that she introduced. One, the Kiwi Bank. These are economic initiatives to help the population. Started the New Zealand Superannuation Fund, started the New Zealand Emissions Trading Scheme. Look at those economic changes. Started Kiwi Saver, oversaw some, the Foreshadow and Seabed Act. And in foreign affairs, she contributed troops to Afghanistan, but did not take part in the Iraq War. And she ordered the deployment in 2006, a deployment of troops to East Timor-Leste during their troubled times. So she had very strong economic changes for the country, but she also participated in international affairs. And that is what she's known for. Today, she also served for 2 terms in the UNDP, United Nations Development Program. And she served 2 4-year terms, and she's known for her strength. Now let's look at the few lessons that we can learn from these leaders from Australasia. Women leaders can institute changes that bring economic gains for everyone in the country, but more so their women folk. Lesson number 2 is good to tighten firearm laws, and that is a sign of pragmatic leadership. In dealing with COVID-19, she adopted, or these leaders adopted what is called the elimination strategy, and this is associated more with Jacinda Ardern, who considers herself as a pragmatic, her mode of politics is called pragmatic idealism. She's no longer in politics now, but she still pursues matters of social concern. These people have won awards, and they have also been listed among most influential people in the world. So it's important that we look at what they did well and learn from them. Female political leaders can get to power, but it doesn't stop you from going on with other aspects of life. Like this lady got pregnant, gave birth, took maternity leave, then after that, she came back to office. She's only the second person leader in the world to do that. So that's quite significant. Then by taking a strong stand on issues that she did not agree with, her country was placed one tier lower. The US considered New Zealand as an ally rather than a friend. And that was supposed to be a kind of a demotion of sorts. But not to worry, these people still stood for what they felt they believed in. Then finally, male chauvinism can be confronted head on, just like Julia Gillard did. Women should not fear men, and they should use their positions of power when they can to confront male chauvinism head on. Now, so there is a lot to learn, and like I said, with only 10 minutes to present, I would not be able to expand on those themes further. Only to say thank you very much for giving me this opportunity, and I hope to be part of this going forward. Thank you very much.
Thank you very much, Swata. We appreciate the time difference, so thank you for availing yourself. And I'm sure you have motivated some Kenyans to do the same on our political women who are in leadership. Our fourth presenter is Abigail from Kenyatta University, representing Professor Grace Gary. Let's observe our 10 minutes.
Good evening. The slides, please. My name is Joanne Rakomi. I'm not Abigail, but I'm presenting together with Abigail. The slides for the systematic review. Yes.
Maybe you can continue as we wait.
Yeah.
Yeah, yes. Thank you.
Yeah, thank you. So we are going to present on a systematic review on microfinance interventions and violence against women and from low and middle income context according to the definition of World Bank. It is a study that was conducted together with the Kenyatta University and Johns Hopkins University. That is students and the lecturers. So basically we are looking at violence against women because studies indicate that this is a big thing because, you know, 1 in every 3 women has experienced violence. That is physical, sexual, and emotional, and that includes partner violence, though most studies do not disaggregate as such. And the economic empowerment interventions are used to prevent violence against women because one, they increase the agency and also help women to make decisions. However, again, in some instances, you know, they really start the status quo and they end up causing violence. So that is why it is interesting to look specifically around this microfinance and their effects on violence. And there are gaps whereby you find that there is lack of measurements in the programs that do economic impact. Sometimes before assessing whether violence has been done, it is important to also show the impact. You know, sometimes we just go and look at was there violence, but we've not shown the impact. So that is one of the things that our study is looking at. Then 2, clarity on the effects. That is, if you are adding the supplemental program, for instance, the program had an economic arm, but they added something, for instance, training. So we look at both and compare which one is better than the other. And then clarity on the mechanisms that were used in reviewing. That is, ours focused only on microfinance and not mixing, you know, issues around any other like livelihood, cash transfers, and all that. So the aim for this study particularly is we assessed the materials that or the studies that were published from 2015 to 2023, looking at the effectiveness of microfinance in preventing violence against women, as already indicated. And just looking at economic status, the types of programs as already mentioned, and the mechanisms through which these microfinance interventions contributed to reduction of violence against women. And as mentioned, these were already looking in the low and medium income countries. The methods that were used, we searched the databases, different databases, and put the materials in the Covidence. And then from Covidence, we were able to screen the titles and abstracts. And then those that ticked the box based on our eligibility criteria, we were able to extract the information and then did the scoping, that is screening and extraction. For all this time, at least 2 reviewers were doing it. And then in case there is any something that maybe there's a discrepancy, I might tick it and the other person does not, then there was a third person to be able to qualify it. So those that qualified were synthesized, and then against there was the microfinance effects that was comparing women in the microfinance program to women who are not in the microfinance program. There were those for plus effects, that is comparing women who are in microfinance program plus maybe being trained as supplemental programming vis-a-vis those who only receive the microfinance program. And then we had the embedded effects that were comparing the women in microfinance program and also had supplemental program vis-a-vis the women who did not receive any combined program. So the results, Abigail will be able to share the results.
You have 3 minutes to do that.
Thank you. So my name is Abigail Malelu. I am a student at Kenyatta University, and I'm going to take you through the results. And somehow I have this, but still I cannot see there. So I'm going to use this one. Thank you, Joanne. So we start on the results. So like you've been told, our study was looking at the intervention of microfinance in reducing violence against women. And in terms of the results, we find that in the study, so looking at the violence against women outcome, those that looked at intimate partner violence, we had 21. Like you've been told that we had 27 studies in total. 21 of them were able to look at the impact of intimate partner violence. Also, we had 5 that looked only at violence by any perpetrator. We had again violence from a paying partner or a client, and we had 2 that looked at harassment. Then, like we've been told, it is a systematic review that focused on experimental studies. So there were 16 that were RCTs, that is the randomized controls trials, and then we had 11 that looking at quasi-experimental. And of course, like we've talked about, microfinance program intervention can be given out to groups and also to individual groups or individual persons. So we had 18 for groups and 9 for individuals. Then population again was distributed, looking at partnered women, the youth, sex workers, and locally defined income eligibility. And also we had 3 that were concentrating in conflicts setups. Then we had a total of 41 trial arm comparison with 16 that were very rigorous and 25 that were non-rigorous. So we look at the results. Next slide, please. Thank you. So in terms of looking at microfinance effects, like we've said, we had 10 that looked at microfinance effect. And in terms of the results, we find that giving a microfinance intervention in 3 studies, they found that it reduced violence against women. But in 1, we had violence against women increasing. And in 6, we had null, meaning that there was no relationship found between the microfinance intervention and violence against women. Looking at embedded microfinance effect, this is whereby we had a microfinance and we had supplementary programs. We could have, like she explained very well, a program on gender, rights-based nutrition, and etc. So we had 3 that found reduction in violence against women. We had again 1 that's violence against women increased. Then we had 12 that had null effects. Plus effects again, where we had a microfinance against a control group, whereby they didn't receive any. 5, so that for this one, violence against women reduced in 5 studies. In 1, it increased, and 9, there was null effect. So for those that were rigorous in terms of their experiment and their methodology that they used, from the 2 that were there, so there were only 2 for microfinance, 1 reduction and 1 null effects. For embedded, we have 10, in total they were 10, but 2 reduced and 8 null effects. So just to move on, maybe to have a discussion in terms of, so like you can see, in most of these studies, we can see that we are having null effects, whereby you introduce a microfinance program, but there is no effect in terms of reducing or increasing violence against women. At the same time, you can see that we have an increase. So
women who maybe are being given some cash transfers or they are involved in getting any form of microfinance, there is reduction in violence against women for them. In terms of discussion, we find that in those that they were receiving microfinance intervention, and then there is increase in violence against women. The increase comes whereby there is the women attitudes towards violence changes. You find that when we look at studies in terms of violence against women, we look at the attitudes. Do you accept violence? Is it okay for a woman the husband to beat a woman if she burns food, or she maybe goes out and leaves the children without attending to them? So you'll find that in most societies, like we saw, this is a low, middle and low income countries, you'll find that most societies are receptive to women being disciplined by the husband because of that. So when a microfinance intervention brought some changes in terms of that, there was increase in violence. Then in terms of male engagement, in some of the trials, we have the husbands or the partners or male relatives being involved in the supplemental programming. And you find that so we had 8 that had male engagement. In 3 of them, it reduced intimate partner violence. So there was a positive relation in involving male in the programs. However, in 5, there was no impact. What we noted in 3 of them is that there was backlash. I think we've been talking about this since morning, as we saw that most people associate women empowerment to increasing women agency, which seem to be like becoming a rebel or challenging the power dynamics within the family, and this is what can bring about the backlash that we saw. In terms of heterogeneity, we find that violence against women and microfinance intervention, there is a difference. So, for example, among poor women, there was a positive impact in terms of reducing violence against women. Again, in terms of those who are very vulnerable or at risk for intimate partner violence, we also saw a positive impact there. Next, in terms of results. So, okay. In terms of, so the harms, so we can see that backlash, like I've already discussed. So, so that one, we just have some of the programs that were being introduced and the impact they had. So having, I reorganized my thinking into just finishing. So women receiving self-help groups, which led to less domestic violence. The second one there, we have women undergoing training in savings and loans plus a curriculum. And the impact there, we have decreased physical sexual violence. So in terms of conclusion, because of time, so we can see that microfinance continues to show promise in reducing violence against women. So that economic empowerment of women, there is a promise that it can be able to reduce violence against women. However, like we saw, there were so many studies that had null effects, meaning that, again, there is a gap somewhere in terms of microfinance and how it impacts on violence against women, and also looking at the supplemental program. So if we are giving a gender program, in combination together with the microfinance, why do we have a null effect? So all those things, again, there is future studies that should look at it. And therefore, in this study, we recommend doing a microfinance only intervention against a control group that is not receiving any, so that you can be able to understand the impact of microfinance in reducing violence against women, or the association, without now having the supplemental programs in it. Again, we recommend having a rigorous study so that you can be able to understand which aspect of the supplemental program. So is it gender? Is it the nutrition? Is it a study about masculinity? What study will you give? What additional program will you give for it to be more effective to be able to reduce violence against women? And we conclude by giving the last slide. So, in case you are interested in understanding more about women economic empowerment and its association with intimate partner violence, so you can be able to get this slide and you can scan and you can be able to get this other study that it's a brief on how women economic empowerment interventions influence intimate partner violence among heterosexual women who are cohabiting or living with their male partners. So I do welcome you to go further into this site of Prevention Collaborative to be able to understand more about the association between women economic empowerment and intimate partner violence. Thank you so much for listening.
Thank you, Joan and Abigail, for that presentation, and also for giving us the option that you'll share with us for better reflection. Thank you for that. Our final presenter is Judy Ngina from International Center for Reproductive Health, Kenya. Karibu.
Good evening, everybody. I'm speaking from a point of disadvantage. Let me borrow the words of Daktari. Being the last speaker, I know we are so tired. But let me begin my presentation by asking us a rhetoric question. How many of us in a public space, maybe you're in a matatu area or just anywhere in the public, you had somebody use abusive language, or maybe you stepped on somebody and they responded using maybe how do you call it, ngumi, a fist, or just any violence you experienced in a public area? How many of us have experienced that? That's the first question. And then my second question is, did you report it? Did you report it? From your facial expressions, I get the answer. And that is what I'm going to be talking about today. IPV, intimate partner violence, and non-partner sexual violence. Non-partner sexual violence being the violence we experience in public spaces from a non-partner. The title of my presentation is Help-Seeking Behavior Among Young Women Experiencing IPV and Non-Partner Sexual Violence in Nairobi, Kenya. These findings are part of a larger study that was conducted by International Center for Reproductive Health and the KU Rehab in collaboration with Johns Hopkins University. And before I even begin, let me introduce myself. My name is Judy Ngina. I'm a Johns Hopkins gender scholar, and I'm also a PhD candidate at the University of Nairobi. So this study that I'm talking about is a panel study which the first participants were interviewed or participated in the study in 2019. And in 2019, we had 1,357 participants, but we followed them through to 2023. And in 2023, we retained 550 of the young women, and we added an additional 281 to make a total of 831. So 831 is the number of females that I'm going to be talking about in my findings today. And so IPV is a major public health concern, and it is quite unfortunate that 1 in every 4 women are reported to have actually experienced IPV at least once in their lifetime. It is saddening that our statistics in sub-Saharan Africa are quite higher than the global statistics in terms of IPV. We have 36% in sub-Saharan Africa, while globally it's 30%. The true prevalence of non-partner sexual violence is not known for simple reasons. Most of us don't report it. In Kenya, we have, our statistics also don't reflect quite well. We have 71% of women experiencing sexual violence reporting to have had that experience of sexual violence to be by an intimate partner. So 71% is IPV in Kenya. And the age of a woman, where she lives, the wealth quantile determines her violence outcomes. And access to justice still remains a challenge in Kenya. So what were the findings of our study? Just a general overview of our participants. And the demographics, we had children, that is 15 to 17 years, making 2.4% of our participants. And then majority was between the ages of 18 to 29. Most of them lived with a partner. Most of them were out of school. Most of them had one sexual partner, but we have that figure there that had more than 2 partners. Remember, our age cohort is 18 to 29, and this percentage had more than 2 sexual partners. Then their marital status, most of them are not married. And still also remember, most of them, this percentage having more than 2 sexual partners. And we also have most of them having attained secondary or lower education. From our qualitative results, the main themes that were coming out were culture, and we talked about it in the morning. It's an evasive discussion, but we will see that culture plays a big role even in help-seeking behavior and even in giving services. We have seen instances where a lady goes to the police station, and because the culture of that police officer dictates that IPV is a family matter, then that woman is referred back to her family to have conversations and to sort out that issue. So culture also, in as much as it's an evasive discussion, it still plays a role in help seeking for women experiencing GBV. This particular quote, a police officer asked this 19-year-old female participant to return and get raped so that they can have evidence. And it begs the question, while we are empowering our police officers in terms of polycares, we have the gender desks, we have the Kilifi representatives who talked earlier, who mentioned about empowering their police officers in their gender desks. Are we doing it the right way? Is there more to be done? Or what else can we do so that we cannot see such statements from a public officer who is supposed to respond to incidences of violence? Okay, we have this 17-year-old woman who talked about not having evidence of verbal abuse. And she says, I won't have any evidence of verbal abuse, and I can't go to report. And this was a context of she's in a matatu, she's in a bus stop, and she gets abused by the tout. And so she was asked, did you report? And she was like, I don't have evidence, which is true. By the time he's abusing you, you don't have your phone to record. Nowadays, Gen Zs are very good with recording. But by the time the abuse has come, you have not recorded it. So most of the times, you don't have evidence for that. And so most of such incidences go unreported. On our quantitative results, most women who have experienced non-partner sexual violence also reported to have experienced IPV. And from the 831 women who were participated in this study, 23% of them reported to have experienced IPV. We also see the reasons given as to why they did not seek help. 22% of the participants reported not to know any services where they could report for non-partner sexual violence. We also have a whopping 20% of women experiencing IPV not thinking that it was a problem. So our women in marriages, do they even understand what intimate partner violence is? It just doesn't stop at my husband beat me. There's more to. We need to unpack what is intimate partner violence and also empower women in terms of what services are available for them. We also have 32% of women experiencing non-partner sexual violence saying that they were afraid to get in trouble. And we have seen this mostly When you report an incidence of violence as a woman, what are the probabilities of you facing backlash? Maybe you are a victim of rape, quote unquote, and you go report, and maybe information leaks. Everybody's going to be pointing at you in the community. She's the victim of rape. She's the one who was, and it's stigmatizing. So, and also the perpetrator, what are the probabilities that the perpetrator is going to come back for you? So many of them don't report for fear of getting into trouble. What are the services that these women sought? The most sought service was counseling. And this form of counseling was either informal or formal from the medical practitioners or the community health workers. Let's look at the percentage for police. This is where the question is. Are we directing our energies to the right direction? Because when we talk about, let me use an example of the Kilifi presentation. There was a lot of heavy resources and attention going towards police empowerment. But look at the number of women who report to the police. So do we take a stand and ask ourselves, are we directing our resources to the right channels, or do we reflect back and say, can we empower the community health workers better and see whether they can be able to help? I don't know. It's a question for us to ask ourselves. So, who did the IPV survivor speak to? Most of them are talking to a friend. Remember, our age cohort is 18 to 29. We also have a few 15 to 17. And none of them is talking to a teacher. So if we have teachers in the room, let's also ask ourselves that question. Are we giving them an ample audience for them to come and talk to us? Yeah, that actually marks the final slide of my presentation. And for more information, this is a Bill and Melinda Gates funded project. And so our data is open source. And it can be available on the PMA PMA website. Thank you so much for that.
Thank you very much for keeping time. You actually just exceeded with 1 minute. Now it's time to ask questions. And let me say 5, but if it won't reach there, it's okay. I'm thinking maybe there'll be a question for each of the presenter. So just 5 max. Max. Yes. And as the mic comes to you, maybe I can start just asking you, in fact. As you are doing your presentation, my thought went to the women you engaged, and I was just wondering, how do we reach them for us to take them to the intervention, or this? How do you get? Because they're so convinced. Some of them are so convinced in what they do. Like, without this, I can't get money. So how do you reach out to them?
Mm-hmm. Okay. Right. Okay. Thank you very much. Let me answer that and then ask my question. Or you want me to ask my question? Okay, fine. So let me ask the question. I don't know if it's a question or it's a comment. Based on the presentation we've just had, I'm familiar with it. But this issue about economic empowerment and whether it's a causal factor in, gender-based violence, that it increases gender-based violence. In the WeHub study we did also, we mentioned that it's got that counterproductive effect. But then based on representatives, I was wondering whether economic empowerment is given to women to prevent gender-based violence or as a response to gender-based violence. Most cases I've come across is that it is given to women who have gone through gender-based violence, maybe were separated or divorced, and therefore they need to lead an independent life, and therefore you empower them economically to do that. But as a preventive measure, I haven't quite come across that, and so I'm not sure what the nexus.
Okay, thank you. 3 more. Okay. There's one right there, Dr.
Thank you so much, Dr. My question actually goes to the last presenter. It's not a question, it is, I think, something that I will want her to tell us. Maybe I missed it. I did not hear in her recommendation something to do with what they intend to do with the young women when it comes to IPV.
Okay, I'm sure she's got it. She'll explain and clarify. Last one. Oh, there's one here.
Thank you. Mine is a general comment. Since we began the conference, I've been listening through the presentations. I don't know if it's the limited time that we have or something, but I'm not hearing us discussing how our findings and recommendations apply to policy and regulations and guidelines so that we can have real change in policy and frameworks and the architecture of our systems to these issues. I've not had it coming out. Maybe it's the constraint of time, but it cuts across all presentations.
Okay, thank you for that. Maybe one of the presenters can, and I'm looking at someone, maybe she can tell us, how was your study, like how can it impact policy and probably practice as well? Do you mind? I've nominated you as the person to answer.
Now, as we work in the informal settlements, and we would rely on such forums to be able to escalate what we do to policy. So it means bigger institutions like the university, therefore, should be able to support in informing policy.
I don't know whether you're okay with that. Yeah, thank you. Thank you for that. Now let's hear from Judy. You had two. Were they two? Were they? Okay.
Thank you, Dr. for the question about the association between the economic empowerment programs in terms of preventing GBV. I hope I got it right. So in terms in our study, in this systematic review, like we've said, most of the study were not able to show that the microfinance effect alone could be able to prevent intimate partner violence, and therefore that is why in the recommendations we ask for further studies to be able to understand the impact of microfinance intervention alone in how it can be able to prevent intimate partner violence. But most of the study that we've seen is that they combine the microfinance intervention together with a supplemental program, maybe gender transformative training, and also male engagement to see if they can be able to reduce. And it has evidence that it has it can reduce GBV by changing the societal perceptions. Like we've seen in one study, we said that the women now attitudes in accepting to be disciplined by the husband had changed. So it has, but we need more studies to be able to see the direct association between microfinance and yes, as a preventive mechanism.
Okay, thank you, Joanne. Is it Joanne or Abigail? Okay. She's responding, then maybe you can, yeah, because we're actually clearing, yes.
Okay, thank you so much, Dr. for the question. And please allow me to. broad. So, the project is actually just a data monitoring and evaluation system. So we work closely with county governments, implementation partners, and of course policymakers to generate evidence that informs policy and programming. And that's why maybe in my presentation did not come out clearly what we are doing exactly, but such data will go a long way to inform policy. And part of the project has also informed the digital health bill that is actually on the table. So yeah, that would be my response to that. I don't know whether I've comprehensively answered you. Thank you.
Okay, she seems fine with that answer. Finally.
Yeah, I'll also say something about the policy issue because I'm involved in this in the Johns Hopkins study and as well as the SGBV team at KU we have. You know, policy takes a long time, and it's not a direct thing that you tell people this and then the next day they have policy. So the strategy that the strategies being used are, first of all, you get this data, and then in the Johns Hopkins, whatever we do, what are called data, awareness workshops. So disseminate this data as much as you can to all kinds of people at community level who can then, using this data, start agitating for policy change. We have had workshops with policymakers, with government people, county government, as well as national people. We do also disseminate, for example, through the media. And I can tell you that out of one of the articles I did on the media, I was invited to a workshop where issues of the triple burden, of GBV, HIV, and teenage pregnancy, was being discussed. And, the presentations here were directly going into informing, policy. So it's a multifaceted approach to, policy influence. Now, to the question you asked me, how do we get these people? These people are sourced in different ways. It's not just the story of Life Bloom is very interesting. That it's a lady who initially was a school headmistress, but who moved into this work because of what she experienced. So she gets these women, first of all, through her own proactive action. Because she decided to do this, she started this organization and she focused on commercial sex workers. So one track she uses is to deliberately go out and interact with commercial sex workers. Because what she's trying to do is to get them out of commercial sex work, to restore their dignity that they can live and earn income without having to engage in commercial sex. That's one track. The other track is that, previous beneficiaries of her program introduce, fellow women to her. So that is now, the alumni, help her to get them. Then there are people who just know that this program exists. And so they also introduce potential beneficiaries to that. And the interesting thing is that not everybody who lands there is a commercial sex worker. So they refer anybody and everybody. But then now LBSI will sieve them and see, okay, this one belongs to us, and then refer them to other service providers. At Makueni Gender-Based Violence Recovery Center, of course, the track is some come from the police because that center works directly with the police. So the police receives them, and then after taking their statements, refers them to that center for this help. Some go there directly. Some come as patients to the hospital, and then the hospital refers them to that particular center. So again, a multiplicity of sources. Thank you.
Thank you very much. We've come to the end of that session. As I hand over the mic to our chair here, I just want us all to appreciate all the presenters. That was awesome for me personally. I've learned a lot. I'm new in this space, so trust me, through sport, we are going to be, is it agencies? So yeah, thank you very much. Let's appreciate them as a handover. Thank you.
Thank you, Chair. It was quite something, but you managed. Now we've come to the end of the session, and tomorrow is our last day, and we will start the registration early. So all those people who will be doing the presentations, come early, register early, then we can be able to proceed. Secondly, there's a cup of tea there. As you leave, take some tea as we leave. And all of you, thank you so much. And I want to ask Dr. Pacifica to pray for us, my senior.
Thank you very much. Let us believe and pray. Our Father and our God, we want to thank you so much, because when we started the day, we asked for your guidance, we asked for your wisdom, and we asked for your protection. And Father, you have given us all this. And now as we come to the end of the day, we want to appreciate you. And we want to really ask that even as we proceed from this space, you take care of us. Father, we know that there is a lot happening in our nation, and sometimes we cry for our children. Sometimes we are worried and asking ourselves whether we shall get home. But because you will cover us with your blood, with the blood of your Son, Jesus Christ, we shall get home. And Father, may we travel safely, and when we get home, we remember to thank you and praise you. We thank you, O Lord, for the We workshop, because of all we have learned. And we pray that you guide our steps as we continue in this particular journey of empowerment. And now, Father, as we exit this space, we simply want to appreciate you and worship you. We pray all this, believing in the name of your Son, Jesus Christ, our Lord. Amen. And now may the grace of our Lord Jesus Christ and the love of God and the fellowship of the Holy Spirit be with us now and forevermore. Amen.